Welcome to another edition of Time-Based Health, a program that discusses different issues affecting health sector. In our today's episode, we're in Katsina State, where to discuss will be Director General of Katsina State Health Contributory Healthcare Management Agency, Muhammad Safana, where we are going to hear how far so far the agency is faring in Katsina State. Muhammad Ibrahim Safana, let's start from the little history of this agency.
The Katsina State Contributory Healthcare Agency was established on the 18th of December 2018 by the Executive Governor of Katsina State, Right Honorable Aminu Bello Masari, to purposely ensure that all residents of Katsina State has easy access to healthcare. And that came as a result of the plea or the call by the National Health Insurance Scheme to ensure that states joined the strive for universal health coverage. We all know that the presidential mandate of universal health coverage was mandated to the National Health Insurance Scheme to ensure that each and every resident in Nigeria has access to healthcare. And the National Health Insurance Scheme cannot do it alone. So it has to collaborate with the states governments for them to establish their own agencies based on their socio-economic and political differences they have. And that's what made Katsina State government to decide on establishing such an agency. This agency, after the establishment and the appointment of substantive Director General, the first thing we did was to have what we call baseline assessment survey. Baseline assessment survey is a survey to understand the status of Katsina State in terms of healthcare. And interestingly, we found out that about between 35 to 45% of income earned by state civil servants average is being spent on healthcare.
So it means civil servants are left with at least 75% out of their salary.
Yes, what I mean, yes, exactly. Virtually about 65% is being left for them. So between 35 and 45% of their income is being spent on healthcare. And that is what the United Nations termed as a catastrophic health expenditure. And that is what the agency is trying to bring down to the minimum level. And that's what forms the basis for us to sit with other stakeholders to see how we can determine percentage contributions of their salaries together into a pool so that we can effectively manage and provide easy access to healthcare services.
So in your own system at state level,
yes.
How many percent is civil servant contributing and what is the percentage of government contribution?
Okay, the state civil servants contributes 2.5% of the consolidated salaries of the state. And the state government is contributing 1% of its consolidated revenue into the agency as their equity fund.
So now when we talk about the percentage of the workforce of Katsina State, how many percentage are you able to cover for now?
We have a total labor force of 69,753 workers. So including their spouses and 4 biological children, so far we were able to cover 255,876 enrollees. Out of those 255,876, we were able to actively verify 196,640 that currently are accessing healthcare. And I believe by the 5th of August, we would have 236,000 eligible enrollees within the scheme under the formal sector program.
So now we are talking of formal sector.
Yes.
Before we go to the informal sector, let's talk of private sector, because all this, if a state civil servant can spend up to 25% of his salary, it is also applicable to a private sector worker.
2.5%, sure.
The same percentage.
Yes, no, for the private sector, what was obtainable from the private sector is this 2.5% of the consolidated salaries of the state civil servants. When you take it back to on the private sector, directive, 10% of that amount is being paid by the employer and 5% is being paid by we have 15% of the salary of organized private sector being paid as contributions. 10% is going to be paid by the employer and 5% is going to be paid by the employee.
Have you started enrolling private sector?
No, we have not started enrolling private sector because we are still enrolling the formal sector program. We have to finish. But the moment we finish, we are going to start with the private sector and the informal sector programs.
So it means the issue of private enrollees does not arise for now?
Yes, for now we don't have. We only have the formal sector enrollees who are the state civil servants.
And recently, I love that federal government under the universal health coverage is giving, is it a grant or counterfunding to agencies like yours to cover vulnerable and less privileged?
Yes, that is what we call the Basic Healthcare Provision Fund. You see, the Basic Healthcare Provision Fund, there is 1% consolidated revenue of the state, of the federal government, that is coming to all these agencies as equity grants to take care of the vulnerable population, which includes pregnant women, children under 5, the aged, the disabled, those that were displaced as a result of banditry are all part of this targeted population that these monies are going to be covered.
Have you received such intervention?
Yes, we have.
So if you received such intervention, what have you done now with such intervention?
Right now, as I'm talking to you, we have just, we're expecting our approval from the National Health Insurance Scheme to start enrollment of beneficiaries into the scheme. With the quantum of amount we have on the ground, we can be able to cover 53,700 enrollees.
53,700
enrollees. So if you divide 53,000 by 361 wards that we have, you will find out that we will have at least 147 enrollees per political ward of the state. So that is our targeted enrollment.
So do you have the statistics of such people, vulnerable and less privileged?
Yeah, sure, we have.
What is the percentage? What is the estimate?
The estimated number that we have, as I said, is 153,000. So in each and every local government, we have a targeting mechanism through the traditional institutions, through the emirs, the district heads, the village heads. That is how we are going to identify those vulnerable population and we enroll them into the scheme. And we all know that we have existing primary healthcare centers across the wards. So each ward has one primary health center that is going to be used as primary healthcare provider for the basic healthcare provision.
So you're talking of using PHCs in
Yes.
providing such services.
Yes.
So actually, mostly we know the condition of the primary health care in different rural areas.
Yeah.
Do you think they can cater and provide such services effectively?
Yeah, well, you see, there's one good thing about Katsina State system. First of all, we have a lot of healthcare facilities, primary healthcare facilities that were accredited by this agency to give primary and secondary services under the formal sector program. So that means we have already ensured that such facilities are good enough to give our services. And those that were not accredited by the contributory agency, as I'm talking to you now, the primary healthcare agency is making all efforts to upgrade their facilities. In short, most of them have been upgraded. We have just few that are still ongoing, and some funds have been distributed or supplied to those healthcare facilities under the other gateway for them to ensure that they have provided all the necessary inputs for our agency to effectively enroll our enrollees and maybe use their healthcare facilities for service delivery.
Before we move to another thing, it means how related is this your program with the primary health care, what they call it, primary health care under one roof?
Under one roof. Yes, you see, that's one good thing about that's one advantage that we are going to take. Now that we have primary health care under one roof that has been implemented in Katsina State. So that means the primary healthcare agency has absolute control over these healthcare facilities.
So since you talk of, even though I know your agency is not receiving donations, your fund is purposely coming from civil servants and
contributions.
Contributions, and such contributions you receive for vulnerable and this.
Yes.
is there any room in your edict or your bylaw that your agency can receive donations from international donors?
Quite sure. We have we have a lot of the act has given us that edge for us to access funds from international donor organizations, from even the internal agencies that are responsible for giving some services that are related to healthcare. We all have that privilege. But for now, we don't have any international donor organization coming in to give us any support.
So how do you plan to draw their attention?
First of all, you know, they said once you have it on the ground, when people come into the agency and see what we have done so far, you know, we are good enough to, have